Hey guys, welcome back to my channel. I hope it's been going well with you guys drafting your supporting information. So in this video, I'll be giving you an overview of my specialty, cancer genomics, and talking you through what the role of a clinical scientist is. I'll try to explain it in real terms, or I'll try to give you a real example of what you probably have been seeing online actually means. So it's just to give you a good understanding, which might help you to draft your essay in a better way. You also need to know that this is not a template on how your essay should be or how you should draft your supporting information. Just see this as a support video in helping you to understand what the specialty you are getting into is, or what the role of a clinical scientist in cancer genomics is. So please, rather than focusing on copying exactly what I'm saying, I think you should focus on understanding what I'm saying, and I believe that will help you to write your probably section 2 better. So yeah, let's get into it. If you're coming across my face for the first time, my name is Cynthia. I'm a second-year trainee clinical scientist in cancer genomics, and on this channel I talk about everything STP. So consider me your STP buddy. So remember to click the subscribe button, give this video a thumbs up, and also click the notification bell so that you'll be notified whenever I post a video. So let's get right into it. So I believe anybody interested in cancer genomics, or anybody thinking about cancer genomics, would have asked themselves, what is cancer genomics? If I'm asked what cancer genomics is, I can go ahead to give that definition, but sometimes when I'm explaining it, I like to start from the definition of cancer to kind of give a better explanation. So cancer happens as a result of uncontrolled growth. I'll be looking at my screen as well. So cancer happens as a result of uncontrolled growth of cells caused by changes in DNA, which are called mutations. And these mutations are what accumulate over time and result to cancer. So in the lay term, some people are always told that cancer happens as a result of something going wrong in the DNA. And then what is cancer genomics? So when we say something going wrong, or when we say mutation, cancer genomics try to find this mutation or this genetic mutation that are driving a patient's cancer. So cancer genomics involves analyzing tumor DNA to identify these mutations. So in simple terms, cancer genomics tries to answer the why behind the patient cancer, or try to find the mutations that are driving a patient cancer. So it helps in diagnosis, prognosis, therapy, clinical trials, and monitoring. But what does this actually mean in simple terms? So when we say diagnosis, it's confirming diseases, giving precise diagnosis, and defining cancer subtypes. So let's use a typical example of lung cancer. When a patient presents to the hospital with symptoms and they are diagnosed with lung cancer, we all know that most times a biopsy sample is taken and it gets into the histopathology lab, and after processing and everything, a pathologist would then review it and probably diagnose that this patient has lung cancer. But it has gotten to a point where we need to further subclassify to identify what mutation is driving this patient's cancer, and that is where the sample is then referred to us in cancer genomics, and which is what you might know as molecular pathology. So we definitely analyze and look through the DNA to kind of identify what is the driver mutation for this patient's cancer. And when you say cancer genomics helps with targeted therapy, this is exactly what it means. So when you identify the mutation that is driving a patient's cancer, then that is what informs the clinician on the exact therapy that this patient should receive. So there are like different mutations that you can find in lung cancer. So two patients can have lung cancer, but they will all receive different treatment because they found different mutations driving their cancer. So when you say cancer genomics help with prognosis and risk stratification, basically based on our findings, we are able to tell how a patient will perform. That is, we might have good prognosis, poor prognosis, intermediate prognosis, or we can call it risk. So based on some guidelines and all that we use in doing our work, we're able to risk stratify this patient. So some genomic changes are associated with disease aggressiveness, likelihood to relapse, treatment response. So based on all that, it also helps to guide the clinician on the type of treatment that should be used for this patient. Again, it also informs clinical trials. So based on our finding, it also tells when a patient is qualified for clinical trial or not. Then for monitoring, when I say monitoring, what it means is we're able to monitor a patient when a treatment has been started, and that way we are able to know when a patient is relapsing, or when the patient is going into remission. So when you talk about monitoring, you can look at maybe most of the leukemias like chronic myeloid leukemia and acute myeloid leukemia, and also in bone marrow transplantation. So we have techniques that we use to monitor these patients to know that if the level is getting down, or if it's getting worse, or whatever it is. So that is the role Cancer Genomics plays in monitoring. But when you talk about the impacts in patient care, it has different impacts on patient care, but the very obvious one is how it has helped to move treatment from one size fits all to personalized care. So what this means is, if people present to the hospital, rather than giving, let's say, everybody with lung cancer the same type of treatment, which is what we used to see years ago, each person is stratified and we look at their own genetic makeup. So based on what is driving their own cancer, that is what will inform the exact treatment that patient is going to get. So that is what we mean by personalized care. So it helps to inform targeted therapy. And what do we even mean by targeted therapy? So targeted therapy is a type of cancer treatment designed to target or attack the change in cancer cells that allow them to grow. So when there are a lot of targeted therapy that are available now. There are so many of them. So when you identify the driver mutation, we have different therapies that have been built for them. So that way you are able to target that mutation or target that driver, and that way the patient will have a better outcome. So you know that some treatment might have adverse effect on some people, no effect on some people, and be good for some people. So rather than one size fits all, we've gotten to a point where we have personalized care. So everybody will be treated based on the genetic makeup or whatever is driving their own cancer, and that is a direct impact Cancer Genomics has on patient care. So what then is the role of a clinical scientist in Cancer Genomics? I'm sure if you look online, one of the things you will see is that a clinical scientist in Cancer Genomics analyze, interpret, and they report genetic results. So in actual sense, what does this mean? So I'm just going to paint a picture for you guys of what actually happens in the lab. So when we receive a sample and it is processed, we have the technical team that do the processing. So after processing, we have the data that gets to the clinical scientist. If you leave that data, no one will be able to make any actionable decision. When I mean no one, I mean clinicians will not be able to make actionable decisions based on that. So someone needs to interpret it. It's very different from biochemistry or hematology, where some of the tests like full blood count already have the baseline and all that, where someone can look at it and be able to tell if this is high or if this is low. Genomic results, some of them are very complex, and someone needs to analyze and interpret it so that an actionable decision can be made on it. That is the major role of clinical scientists in Cancer Genomics. So we have cytogenetics, molecular diagnostics. So we have these are different teams that you find in the department. So it's not like they're all working on the same thing. They all have different things that they are all working on. So when I say cytogenetics looks at chromosomal abnormalities, and in cytogenetics we use techniques like fluorescence in situ hybridization, karyotyping, and microarray. So these are techniques that help us to identify chromosomal abnormalities. In molecular diagnostics, we have looking at the solid cancer and the hematological malignancies, which are the blood cancer. So there we use techniques like next generation sequencing and PCR, and these are what we use to identify different variants and also different genetic mutations as well. So when I say chromosomal abnormality, a typical example would be if we receive a referral and they are querying chronic myeloid leukemia, then after processing, when you use fluorescence in situ hybridization, we also call it FISH. So we'll use FISH to see if there is a rearrangement between chromosome 9 and chromosome 22. So we call that the 922 rearrangement. I don't want to go too far, but just try to look at it from this way. So we have the BCR gene and the ABL gene. So you can find them on chromosome 9 and on chromosome 22. So if there's chronic myeloid leukemia, then they will fuse together, and we are able to identify that using karyotyping and FISH. So after that, a clinical scientist would do that analysis to find out, is this rearrangement there? And if that rearrangement is there, then that will be reported back to the clinician. We also have different guidelines that we use, and also the WHO that we also use to base our reporting on. And that way we are also able to report, oh, this is adverse risk, this is intermediate risk, this is low risk, and that way it informs the decision of the clinician. So that is actually what analysis, interpretation, and reporting means in cytogenetics. So when you look at next generation sequencing is a high throughput technology, and it sequences multiple genes at the same time from different patient samples as well. So when this is done, it goes through the bioinformatic pipeline. So the bioinformaticians are the ones that kind of clean the data, and that way we are able to just get the variant. So the clinical scientist is then going to analyze that. So they look through they'll do the quality metrics and look through different in silico tools, or let's say computational tools like ClaimVar, Nomad. There are so many of them and they also search through some literature, and they do so many searches to kind of confirm, is this variant, is it a pathogenic variant, is it non-pathogenic, and that is what is going to inform their research. Then when you talk about HemOnc, we have clinical scientists that use techniques like PCR to do monitoring. So when a patient has been confirmed to have chronic myeloid leukemia, we have a way that we monitor what we call the transcript. So this patient has been confirmed to have this disease, so we have a way to monitor when is this going down or not. So when they keep coming to the hospital, we get a sample, it comes to us. So a clinical scientist is what is going to look at this data once it's back from the lab, analyze it, interpret whatever he or she has found, and then report it back to the clinician. So when you say analyze, interpret, and report, that is actually what it means. So look at it from the simple terms of, when this data is back from the lab, somebody has to analyze, interpret, and then report whatever they found to the clinician. And that is what is going to guide targeted therapy, precision medicine, or the treatment that that patient is going to receive. Again, I talked about the sample. I kind of mentioned the sample pathway earlier. Another major role clinical scientists play in the lab is they triage these samples when they come into the lab. So when we receive this sample, someone has to decide the test that is going to be performed on this sample, and that is what the clinical scientists do. They call them the duty scientists. So that is actually part of their role. So they triage this sample to decide the most appropriate test for that sample. So just like I mentioned chronic myeloid leukemia earlier, so if it comes in with a query CML, then the clinical scientist is going to triage, look, have we received this look through the limb system to see, have we received this patient before, what kind of test should be done, are we going to do FISH and karyotype, what are we going to do, blah blah blah, is this testing correct? Because sometimes a clinician might request for something and probably they have requested for the wrong test. So when that happens, it's the clinical scientist that will decide all that. So they have very good clinical knowledge, and based on what they are seeing on the test request, that helps them to decide what assay or what processes or what tests they are going to run on that. And that is the triaging part of their role. So they do that, and after triage, then the technical team will then perform the actual analysis in the lab, the assay, and then when we get the output, then the clinical scientist will also come in again to do the analysis, interpretation, and then reporting. Then we have the role they play as part of the multidisciplinary team. So when we say multidisciplinary team, it's just like a team that is made up of different healthcare professionals, where they come together and they look at the patient result, the details, even the result we get, not just from Cancer Genomics, but we have like an integrated report of everything we have on that patient, and then they decide what is the best treatment for this patient. So clinical scientists are also part of the MDT, and sometimes they attend MDT meetings as well. So if a result is not clear or if they have questions, they ask the clinical scientist and they answer that question. Sometimes they also exchange emails, or if we've received a request and we're not sure, we can email the clinician and ask questions. So that's like working as part of the multidisciplinary team. They don't work alone, so we work as part of the MDT to ensure that we are giving the best care to our patient. Then we also have the role they play in quality. So when I say quality, it's a whole big deal in the NHS. So you cannot talk about the role of a clinical scientist without mentioning quality. So they work as part of the quality management system. So they support they support audits, they report and investigate non-conformances, and they come up with corrective and preventive action. So the labs are diagnostic lab and they are UCAS accredited. We have regulatory standards that we are supposed to maintain compliance with, like we have what we call the ISO 15189. I hope that is correct. We have that. So these are standards, these are regulatory standards that we are supposed to meet. So they help to make sure that we are that the lab is compliant with that. So like this is just like the quality aspect of their role. Then we also have training. They train STPs, they train other members of the team. We have people coming on rotation. So when this come up, the clinical scientists are heavily involved in training. Then they also have the troubleshooting part of their role. So if an assay goes wrong or if something goes wrong and all that, they kind of investigate and all that and try to troubleshoot and solve the problem. So troubleshooting and problem solving is also part of their role. Then we have research and service development, which is where I believe most people get it wrong. Because when we say research, they try to see it from the academic side and maybe think that they are doing one. It's very different from an academic research. So when you think research and service development, you should be thinking validation, verifications, and implementation. So a typical example would be if a new assay or a new kit is going to be introduced to the lab, then somebody is going to research on it or kind of do a validation research. So if a manufacturer has produced this and they say this kit or this assay does this particular thing, then someone is going to validate or verify to know that this software or this kit is doing exactly what it says it does. So that's like the validation. They also, after doing that, then you go through the process of implementing it. So these are like some of the things they actually do. They also have what we call the continuing professional development. So the cancer, so we know that clinical scientist is a protected title and is HCPC regulated. You are supposed to regularly keep yourself updated. So that is what we call continuing professional development. So this is basically just an overview of what cancer genomics is and what clinical scientists actually do. And this part actually confused some people because I've seen some people asking me, so what then is the difference between a clinical scientist and a trainee clinical scientist? I think the difference is very clear. A trainee is just a clinical scientist in training. So you are training to become a clinical scientist. You don't have a HCPC registration, but a clinical scientist are HCPC registered. We also have what we call authorization of result, which is also part of the role of a clinical scientist. So usually in the lab, we always have two people that are analyzing a result. Right, yeah, so some of the analysts are not HCPC registered. So but after the first analyst, we have something that we call authorization. So it must be a HCPC registered clinical scientist that will do the authorization, and that way it's just like reflecting on the responsibility that comes with that. So you are just saying that you've looked through this report and you think everything is fine and correct. So it's just like the responsibility that comes with it. You can think of the ethical part of the role as well, which comes with things like managing patient confidentiality and also going through that process of authorization. You are like taking responsibility for this result. So that is also part of what they do. So a trainee clinical scientist cannot authorize the result. So currently, as a second year STP, I'm going through the different trainings that actual clinical scientists to do. So I go through all the departments, all the mini teams. Like I do the cytogenetic part, I do the hemonc part, and then I do the solid. So when I say solid, we mean solid cancers like lung and colorectal. And when I say hemonc, I'm talking about the blood cancers. So I will go through this, and I'm expected to be able to do all this analysis. So that is why I am a trainee clinical scientist. So somebody might just show you how to do these things, and then you try them out on your own. And at the end of the day, when you become competent, you can start doing the first line analysis and the drafting of the report. Then a clinical scientist will look at it and authorize the report. So that is what you do until you get into your third year and you eventually graduate from the STP. So that is the difference between a trainee clinical scientist and a clinical scientist. So with this, I believe you have a better understanding of what Cancer Genomics is about. So in your section 2, what is your understanding of the role of a clinical scientist? You should be talking about what you actually understand about the job these people do. So rather than spending time to talk about yourself and the things you've done, you should be spending that time to explain what you understand by the job these people do. And you should not forget to mention the impact it has on patient care. So if you are going to mention anything about yourself, then it's just to buttress a point and not to just turn that path to start talking about yourself. So again, for people that are in genomics, you can find this beneficial as well. I know that I've been focusing on cancer and all that because that is just my specialty. But if for someone in genomics, the only difference between the two specialties is that genomics is focused on rare disease and rare and inherited disease, where we are talking about newborn screening, prenatals, postnatals. You have diseases like Down syndrome, Huntington. So those rare and inherited diseases are what they look at, but we use the same techniques, the same cytogenetics and molecular genetic techniques like qPCR and NGS. We use the same technique. For cancer, we look at both the solid and the hemonc cancer. That is just the difference between the two specialties, and the role of the clinical scientists are just similar. Again, just the disease different. So I hope you guys find this helpful. Again, I'm just going to reiterate, don't use this as a wording for your own section 2. This should be just a guide to help you to understand the role better, which might also inform and help you in your writing up your section 2. So in summary, Cancer Genomics tries to answer the why behind the patient cancer, so finding the mutations that are driving a patient cancer, and clinical scientists in Cancer Genomics analyze, they interpret, and they report the genetic result back to clinicians, and that will inform that will help to guide targeted therapy and precision medicine to inform clinical decision making on a patient's care. I hope you found this helpful. Drop your questions in the comment section. I'll try to answer them, or you can try to message me on Instagram, STP with Cynthia. Like this video, give it a thumbs up, and I wish you all the best in your application. Take care. Bye.